The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting this podcast, and thanks to everyone for listening in. Today's topic is going to be a bit intricate here. We're going to try and keep it hopefully a rather medium length, but it could go a little longer just given the complexity of what we're talking about. The topic is about the Medicare Advantage risk adjustment process and why I believe MA plans really have to be ready for some changes in the future, just given some of the political landscape and some of the advocacy by some of the opponents of Medicare Advantage for reform. We'll be taking a couple of breaks as we always do here, but let's start out first with how risk adjustment works within the greater rate setting process of Medicare Advantage. We'll spend some time on that first, take a break, and then we'll go a little more in depth into some of the controversies and what I expect to happen. So, as everyone knows, Medicare Advantage has roughly 50+% of the over 60 million enrollees in Medicare. Again, about half in Medicare fee-for-service, half in Medicare Advantage. And there is a great deal of criticism going on related to reimbursement, and it's very much tied to the risk adjustment process. I want to start out first with talking about rate setting in general. And this also is quite complex, and then we get to risk adjustment, it's going to be even more complex. But let's try and take it piece by piece here. So number one, how do MA plans really get paid? Why are they so successful? And how can they afford to create products for seniors and the disabled that offer far more than the traditional fee-for-service benefits? And I'm going to actually be taking some of this out of my book, The Healthcare Labyrinth, A Guide to Navigating Health Plans and Fixing American Health Insurance. It's available, and you'll hear a little more about that in some of the ads. So again, how are they so successful? And again, it's tied very much to the rate setting process. In large part, it is really that rather intricate process of rate setting in the MA world, along with further incentives built in for high-performing plans from the STAR program. In practice, the actual calculations of these items are significantly more complex than I'm going to be talking about here, but nonetheless, I'll give you sort of the rough framework of it. First, CMS sets a county benchmark that is a percentage of the monthly cost for the average beneficiary in the traditional fee-for-service program. So in essence, Medicare Advantage rates are basically set based on the costs in what is really an incredibly wasteful and expensive fee-for-service program. Depending where you are in the country, the county payment rate can be between 95 and 115% of the projected fee-for-service cost. On average, MA rates are set at about 100% of fee-for-service across the nation. Some rural areas have higher rates against fee-for-service, really a policy decision by Congress to encourage MA participation there, while urban markets are set below fee-for-service at that 95%, just given costs are really very high in fee-for-service, and they wanted to find some accommodation. And while they're paying some greater, they wanted to average out to roughly that 100% of fee-for-service. So again, that county benchmark is set, and plans are able to essentially get up to that benchmark in each county that they're in. So that's sort of the first issue, the county benchmark. The second issue is that health plans in part determine the Medicare payments they receive. Well, how is this? Well, each plan submits its bid for its contract, which could be across many different counties, to CMS specifically for Part C and then also for Part D in the cases of MAPD plans. Now, again, they're separate bids, but they sort of go together, and you're able to use money back and forth if you want to, if you offer an MAPD. But basically, they submit these bids and basically tell CMS the coverage that the plan intends to offer beneficiaries in each county, in each contract, really, that they serve. The plan bids on what it believes its costs are for basic Medicare benefits. So that base bid, so to speak, is based on the basic Medicare benefits. So the so-called Medicare Advantage discount against fee-for-service in that bid can vary widely based on where you are in the nation. MedPAC had a recent report a few years ago that said the average discount that MA bids were nationally against the total of all fee-for-service benchmarks was about 15%. MA plans were bidding about 85% of fee-for-service. But again, this can vary widely. As an example, I used to operate plans in South Florida, particularly Miami. And my experience is that very large population areas like Miami have a much deeper discount. The bid against the basic Medicare benefit in my day was really around 70% or less. So it was about a 30+% discount. And these discounts are bigger in these high population areas because of very high utilization, which is relatively uncontrolled, and even waste, fraud, and abuse. But in a general sense, let's just assume that MedPAC, talking nationally, they indicate that it's about 15% or so. Third, the plan also proposes enhanced benefits for its members that it believes it can fund between the difference between its basic bid and the county benchmark. These added services can include many different things. They can include defrayed cost sharing from what Medicare fee-for-service generally costs, as well as additional services to the members such as dental, hearing, vision, and a whole range of other things. As long as the plan's base rate is below the county benchmark, it is allowed to keep a portion of the difference between the county benchmark and the cost of providing basic benefits to fund enhanced benefits. But as I'm pointing out here, you do not keep all of that difference. Part of that is returned to the federal government as savings, and part of it is passed through for supplemental benefits. So this in of itself is proof to me that MA really does save against fee-for-service benefits. So this difference that they keep between the county benchmark and what they bid for basic benefits is known as the rate rebate. I call it the rate rebate advantage, but it's a rebate, a percentage of the difference between what they bid for basic benefits for Medicare and the county benchmark. So fourth here, I want to point out another interesting thing about the bid structure here is that rate rebate is higher as a plan star rating increases. So the greater the portion of the difference the plan keeps, if they have higher star ratings. For example, a 4.5 or 5-star plan gets to keep 70% of the difference between its bid for basic Medicare and the county benchmark. That percentage must be returned to beneficiaries in the form of enhanced benefits. The federal government keeps the remaining 30% as that cost savings I talked about to the Medicare program. Plans with a star rating of 3.5 and 4 keep 65% of the difference between its bid for Medicare basic benefits and the county benchmark. A plan below 3.5 stars gets to keep only 50% of the difference. If a plan somehow bids above the county benchmark based on the base Medicare benefit and additional benefits it wants to offer, it actually charges an additional premium to the member beyond that Part B premium that everybody pays to Medicare. So that's sort of a quick summation of how things work there. Now, I'm going to talk briefly about the 4-star and greater bonus too, because this factors in as well. So in addition to that rebate I told you about, if a plan rates 4 stars or greater, there's actually an additional 5% quality bonus that is computed into that rate setting system with some savings to CMS as well. And that additional 5% bonus, discounted a bit, also goes back to the member in greater benefits. All told, the combination of the rebate and the quality bonus gives plans rated 4 stars and higher a significant advantage in the marketplace. It can pass significant amounts back to its members in the form of enhanced benefits and lower cost sharing. In 2021, MedPAC said that the national average amount of dollars going back from MA plans to member benefits was about $140 or so. That probably went up since 2021, and it likely will come down again due to some of the rate problems that we've talked about on these podcasts and the fact that plans will have to skinny down benefits. But that's the national average. But what I want to note here is that if you're a low performing plan, you cannot give back nearly as much as that national average of $140. My calculation suggests that, say, a 3-star plan may be able to send back to the member in added benefits somewhere around $65 or so compared to that national average of $140. So just in round numbers, the difference between higher performing plans and lower performing plans might be anywhere from $75 to $100 per month back in added benefits. I think in truth, CMS has devised a rather brilliant system to align toward and reward quality, because they've built the STAR program sort of in that whole rate setting process. With their bonuses and rebates, higher rated plans are able to offer increased benefit levels and lower cost sharing that are appealing to beneficiaries. Higher rated plans grow faster and experience significantly less churn than health plans with fewer than 4 stars. If the plan is run well, the increased membership adds to its profit margin each year too. There is really a direct correlation, in my view, between star rating and plan growth. Doing the right things by beneficiaries leads to higher stars and more business. As an additional bonus, a 5-star plan can market year-round to every member and accept new members throughout the year. So that's sort of an additional way that CMS looks for quality within plans too. So that's just sort of a quick overview of how rate setting works in general. What I'd like to do now is take a quick break, and we'll come back and talk a little bit about risk adjustment to lead into why I think we're going to have changes moving forward.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this podcast about risk adjustment and some of the changes I think may occur over time. We sort of gave you a brief overview about the rate setting process in general. I'm now going to talk about how risk adjustment sort of fits in here. So if that first part was not enough of a head scratcher, here's the other component of that rate setting system called risk adjustment. Rates increasingly take into account the relative health of an enrolled member against others. And what do I mean by that? Well, throughout health insurance, plans like to determine what the risk of their members are, and especially in government plans, agencies like CMS for federal Medicare or state agencies for state Medicaid agencies for Medicaid, and then even CMS for exchanges are rewarding plans in terms of rates based on the higher acuity or risk that a plan has. And that's generally what risk adjustment is in rate setting. CMS has adopted that strategy for MA many years ago. So rates do take into account the health or risk of the member, and CMS pays risk adjustment accordingly. And in essence, I talked about the basic rate setting process, but layered on top of that is this risk adjustment process that evaluates the risk of each member. And we'll tell you a little more about how that happens. And it's additive, it's a multiplier onto the per member per month rate that essentially is bid through the rate setting process. So, anyway, the bid submission process that I noted right before the break, and in fact, the plan's overall revenue is highly impacted by the plan's estimate of how its total population ranks in terms of health against the system overall. This is sort of that risk or the risk adjustment. If its total population is healthier than the system on average, then there is said to be beneficial selection with less overall revenue to the plan in the form of premiums from the federal government. In that case, the overall aggregate risk adjustment of all the member risk scores that are sent in by the plan to CMS would add up to below 1.0, which is sort of the mean or average risk score. If there is adverse selection, that means the plan's population is sicker than the system on average. And then the risk score in the aggregate would be over 1, and additional dollars will be given to the plan member by member, but ultimately rolled up to the aggregate. And that inflates revenue theoretically because of the risk to the plan. As a quick explanation, let's say the population of Medicare has a 1.0 risk score as an average for the entire population, which ultimately is the goal, but we'll get into that controversy a little more coming up. A health plan with healthy members may have an aggregate risk score of all members of 0.9. As I alluded to, that means it would receive on average about 10% less revenue to adjust for its beneficial selection. A plan with an aggregate risk score of 1.1 is sicker on the whole and would receive 10% more revenue on average to adjust for the adverse selection. In this way, plans are compensated again based on the health or risk of the members. So, as I alluded to, the rate setting process just explained before we took a break has a member-specific risk adjustment factor or score tied to the base rate described in the previous discussion. Within the risk adjustment portion, there are really sort of two factors that go into the calculation of that risk adjustment for the member. So that first part is called a demographic factor. And this demographic factor, in essence, takes into account things like age, sex, county of residence, whether you're Medicaid or not, do you have a disability, and some other factors. And so that sort of is the first factor, the demographic factor in risk adjustment. The second factor is called the clinical factor. And in this case, you're trying to ascertain what disease states and thus the risk from a clinical perspective that member has. Basically, plans will submit diagnoses through encounter data, claims data. These diagnoses are then used to identify various disease states or conditions. These disease states or conditions are then grouped together, and they are given risk factors or weights. In the end, what happens is the demographic factor and the clinical component are put together, and that derives the risk adjustment for the member. The risk adjustment is then multiplied by the rate in the area that the person lives, and then you have the complete rate paid for the member. These rates then can be added up into the aggregate. You sort of know, again, whether you're above a mean 1 risk score across your entire population or below 1 across an entire population. So that's just a quick explanation of risk adjustment. So CMS has designed a risk adjustment system for both Part C, medical, and Part D, retail prescription drugs for most beneficiaries. It has very significant impact on the Part C side and less so on the Part D side. Much less of the rates in Part D are based on that risk of the member. There is a community and institutional portion of the main HCC risk model, which is the risk adjustment model. There's also a separate risk model for those with end-stage renal disease. Recently, CMS rolled out a new encounter data process to capture the diagnoses needed in the risk adjustment process. It migrated from a relatively simple submission process to a much more complex one known as the CMS HIPAA 837X12 encounter submission process. This has definitely complicated things for plans, and it did lead to some loss of revenue as that old system was phased out, but now that new system is totally phased in. CMS will begin to audit plans' risk scores because they feel that plans are overcoding, so to speak, and we'll get much more into this shortly. And under that new audit process called the Risk Adjustment Data Validation Process, plans will be audited on samples of the submitted risk scores. Plans will have to provide clinical evidence to support the submitted encounters. And if they're not able to do that, CMS will extrapolate across all of the membership and revenue a penalty that would be recouped from the plans. This is extremely controversial and is being challenged in court, as I've mentioned in other blogs and podcasts. As I alluded to, fee-for-service enrollees get a Part C and Part D risk adjustment factor or score calculation as well. Even though fee-for-service enrollees are not in private plans and are subject to fee-for-service payments, by and large, risk adjustment scores are maintained for these folks to ensure accurate payments in the MA world and in case some of these fee-for-service members enroll in MA plans. Now, a big controversy here, again, is the idea of overpayments, the idea from advocates and MedPAC and other entities that suggests that somehow MA plans are overcoding or not really submitting verifiable ICD-10 diagnoses and generating inappropriate payments. Well, I think that could be true for some plans, and I do think there is some overcoding. But I will also argue that one of the reasons that MA plans may have higher risk scores is because they have an incentive to document risk scores in this process. Fee-for-service providers and the fee-for-service world just don't have that necessity. It doesn't add to the reimbursement. And as long as they put a given diagnosis on a claim, that's all that is needed to get his claim paid, for example, after a service is rendered. But the MA world is different. The MA world is trying to document all of the disease states, and they work with providers to do that. So I think part of the so-called overpayment or overcoding related to risk adjustment is because there's a vast difference between fee-for-service and MA. And we probably have undercoding in the fee-for-service world, not overcoding in the MA world. At the same time, I do feel that some plans have very robust and very aggressive ways of coding that are probably not entirely appropriate. I would note that because of this overcoding, CMS has already placed an adjustment to the overall rates for MA plans. This is known as the coding intensity adjustment factor. It's set just below a negative 6% for each rate. So because of that quote unquote overcoding, there is a downward adjustment in rate setting. Nonetheless, the inflation, so to speak, in risk scores continues to seem to occur every year. Plans will tell you that's because of rising risk for members. Advocates will tell you it's because of ongoing aggressive overcoding. Again, I happen to think that the truth is probably somewhere in the middle. With that, that's our quick overview of risk adjustment and how it ties into the rate setting process. At this time, we'll take our second break and we'll come back to get to the controversies and where I think some of this risk adjustment may be reined in very soon.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back from the break, and again, hope you're enjoying this discussion about rate setting, risk adjustment, and some of the changes that I think will happen in the future. So we know that provider groups, anti-Medicare Advantage advocates and researchers, and even the congressional policy arm MedPAC that I referenced earlier are very busy attacking MA for supposedly being over-reimbursed, overcompensated, overcoding, and risk adjustment. Depending on the study you find, these sort of opponents of MA will tell you that MA is over-reimbursed by as much as $88 billion annually. Now, I think a lot of these studies are hokum, and they're just not accurate at all. Of course, many of these calculations are speculative and throw in policy decisions by Congress to make STARS funding additive, as well as to pay some areas of the country more than fee-for-service. So it's hard to compute overpayment if Congress made a deliberate decision to promote more benefit choice, especially, for example, in rural areas. But these opponents argue that risk adjustment coding is out of control and that MA has beneficial selection compared with the traditional program. Again, I don't believe there's a lot of basis for beneficial selection. There's some very good evidence about the type of folks that MA provides services to, and they actually could have some higher risk than some in the fee-for-service program. I've already told you, I feel that there are some plans that are aggressive on risk adjustment coding, but I do believe that fee-for-service, in essence, undercodes because there's no incentive to accurately code there. So again, as I said before the break, I come somewhere in the middle related to risk adjustment over coding itself. It is strange to me that critics' overpayment estimates jumped from under 20 billion just a few years ago to between 60 and 90 billion annually in the last couple of years. If there was all this overpayment going on, how could it have jumped from 20 billion to 60 to 90 in just a couple of years? And to me, that is evidence of manufacturing arguments, like the idea that beneficial selection has a huge impact between MA and fee-for-service. So I smell a lot of politics around here as well. But as I've said, it's also true that MA plans may need to reform how they approach risk adjustment, which clearly would be the majority of any overpayment calculation, whatever that right figure truly is. The Centers for Medicare and Medicaid Services recently adopted a new risk adjustment formula within rate setting that will in fact take about 7% of revenue out of rates between 24 and 26. This is leading to some consternation and negative financial news from MA plans. But this was a direct reaction to the overpayment concerns. In addition, again, the new risk adjustment data validation RADV rule is meant to globally reduce such overpayments over time. And I believe we can expect far more of this, including perhaps an interim step by CMS of moving that negative coding intensity factor in rate setting from -6 to something greater. So we should be on the lookout for that as MA proponents and plans out there. But let me give you a feel for sort of two areas where I think CMS and researchers may have some, justified reason for talking about overpayments. And this revolves, again, around risk adjustment overcoding in two specific areas. The areas are the health risk assessment game and what I call the manual chart review game. So let's take them one at a time here. Well, first, a new study finds that MA plans that conduct in-home and other health risk assessments are adding considerably to revenue through coding diagnoses from these encounters. So in essence, what's happening is plans are hiring entities to go into the home or in other areas and conduct a health risk assessment. In general, you would believe that a health risk assessment is a good idea. They are mandatory, for example, for certain populations like special needs plans. But the criticism of these in-home and other health risk assessments is that they're really not targeted toward care managing the individual, but simply to code additional diagnoses from that in-home or other health risk encounter. A recent study again shows that there could be considerable revenue through coding of HRAs. So published in a very respected journal called Health Affairs and based on 2019 data, a study finds that when such an HRA is present for a health plan for a member, risk scores increase by about 12.8% on average. Restricting their use, the study says, for such purposes could save between $4.5 billion to $12.3 billion. Now that's pretty significant, and that could be a range theoretically of what overpayments may be here. I want to just give you a quick quote. The researchers found that, quote, artificially exaggerated coding intensity where plans seek to enhance measured health risk through the addition or inflation of diagnoses may threaten payment rate integrity. One factor that may play a role in escalating coding intensity is health risk assessments, typically in-home reviews of enrollees' health status that enable plans to capture information about their enrollees, end quote. And so this theoretical overpayment here tied to HRAs is consistent. This study is consistent with earlier findings of the Department of Health and Human Services Office of Inspector General, which studied HRAs for the 2017 calendar year, so a little bit earlier than the 2019 data. At the time, HHS-OIG found that diagnoses reported only on HRAs and on no other service records that year led to an estimated $2.6 billion in additional risk adjustment payments. And so that's slightly lower than the numbers found in 2019. But in this case, they were looking specifically at diagnoses that weren't found elsewhere. At the time, the HHS-OIG said that the results, quote, raise concerns about the quality and coordination of care for enrollees, the validity of diagnoses reported on HRAs, and the appropriateness of payments generated by HRAs for 2017. Again, note that the HHS-OIG looked at 2017 data while the published study in Health Affairs looked at 2019 data. And it would just seem like the trend is increasing dramatically. Indeed, the health affairs researchers found that 44.4% of MA beneficiaries had at least one HRA. So the use of HRAs have become very prolific and ties more to risk adjustment revenue, in my opinion, than pure quality achievement. So what do these studies really point to? Well, again, nobody wants to take away the idea that health risk assessments can be valuable for care management, nor do I even say that health risk assessments may find diagnoses that aren't there on other claims, and maybe that is not unreasonable. But the data seems to point to the fact that these HRAs are meant largely for coding, and that there's some evidence between the two studies that there are diagnoses reported via the HRA that are never reported elsewhere in the service history of the member. And that certainly, I think, is concerning and needs to be looked at. Let's now turn to the manual chart review process. So the HRA submissions from that review would be submitted as a supplemental submission to CMS. But there's a whole body of other supplemental submissions, which are called manual chart reviews, that go through that supplemental submission process as well. And in this case, plans themselves, or they hire entities to actually go into offices or pull charts from offices and manually review charts for additional diagnoses that weren't originally submitted on a claim. And so basically, again, this is a cottage industry that has really grown over time and become a very substantial part of risk adjustment processes and revenue for MA health plans. In some cases, these manual chart review submissions are not linked to any actual physician encounter with a patient. That diagnosis can't be found on a claim, much like we talked about with health risk assessments in some cases. In other cases, the tie is tangential at best to a claim or a service encounter. The HHS-OIG conducted a separate study of 2016 risk adjustment chart reviews and encounter data that was published in late 2019. And HHS-OIG estimated that $6.7 billion in payments were tied to diagnoses that were only from chart reviews and not tied to any other service event. So similar to their finding on health risk assessments that we talked about earlier. Let's try and put this together. Let's try and combine HRA as an issue as well as manual chart reviews as an issue. And that is, again, courtesy of the HHS-OIG, which came back in late 2021 with an additional study using the same data from 2016 and combining the HRA issue and the manual chart reviews, as I just said. It found that 20 of the 162 MA plans it had data on drove a disproportionate share of payments related to diagnoses that were reported only on either chart reviews or HRAs and not tied to any other service events. HHS-OIG pegged the overall universe of potential overpayments across all the plans at about $9.2 billion. HHS-OIG said that the higher share of payments to the 20 plans could not be explained by their enrollment size. The companies generated payments that were more than 25% higher than their share of enrolled MA beneficiaries, which is pretty interesting. But more important, the 20 companies of the 162 drove 54% of the $9.2 billion potential overpayment, and one company drove 40% of the total amount. So that's extremely significant, very, very interesting study by HHS-OIG. So how do we sum this up now that we've talked both about the HRA potential abuse and the manual chart review potential abuse? Well, I'm going to go back and say, listen, there's probably some legitimate difference with MA plans related to their higher risk adjustment scores than fee-for-service. I truly believe that. I don't believe fee-for-service providers are coding correctly or have the incentive to code correctly, whereas those serving MA plans do. So plans should not be accused of problems there. I do, though, think that there could be some general overcoding that occurs, maybe across the industry to some degree. But more importantly, the data would appear to show that there's likely a very small cohort of what I would call bad actors who are disproportionately overcoding, if that general overcoding is out there, and they're taking a disproportionate share of that revenue. With that, let's take our third break, and when we come back, we'll tell you about some of my thoughts about where CMS may go on this issue.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and I hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're now going to sort of sum up and talk a little bit about where we expect CMS may go on risk adjustment and this perceived overcoding out there. So I wanted to touch a little bit on the fact that in a separate initiative that CMS and the National Committee for Quality Assurance, or NCQA, are currently in the process of phasing out manual chart reviews in the annual HEDIS measure quality submission process. The manual process is being replaced by electronic measure standards. In time, NCQA will also adopt an entire digital strategy for quality reporting. And this will be helped by the adoption of interoperability and FHIR standards and things like that. That will allow information from EMRs to get to health plans quickly and to be analyzed. So the process in the quality world related to manual chart reviews seems like a bad omen for the manual process is still under risk adjustment. If the manual chart reviews will go away and quality performance, is it that much of a stretch that CMS may look to retire manual processes in risk adjustment as well? So what then can we expect to be some of the reforms? Well, I expect CMS to build a policy case over time that both HRA submissions and manual chart review submissions should go away. This, to me, seems like the easiest way for CMS to not attack plans fully, perhaps, on the concept of overpayments, but to sort of use these studies we've talked about to develop a strict policy rationale to rein in overpayments related to the HRA and manual chart processes. CMS will argue that if a plan cannot submit a diagnosis based on a clinical encounter with the provider, it should just not be eligible for consideration in risk adjustment. And while I'm a friend of MA, it is hard to argue the point. While I disagree, again, with the huge overpayment estimates, it's clear that some reforms are needed based on what I talked about HRAs and manual chart reviews. Diagnoses for risk adjustment that are tied exclusively to HRAs and chart reviews, to me, seem very questionable. And the data would show that there are clearly, again, some bad actors out there that probably are taking a disproportionate share of the revenue and giving the entire industry a bad name. and that magnitude of their behavior tends to skew data and again cast all MA plans in a bad light. CMS will likely bar or at least significantly restrict the ability to add diagnoses to risk adjustment based only on HRAs. Indeed, the HHS-OIG says it will issue new findings on the topic sometime in 2024 based on 23 data, so it will be very, very up to date. And MedPAC has recommended excluding diagnoses tied only to HRAs from risk adjustment calculations as well. On the manual chart front, I think CMS likely will create an agenda to restrict manual chart submissions over time and ultimately bar them. So let's talk about maybe a possible timeline. How might this roll out? Of course, all of this is just speculation on my part, but consider the following. So let's talk HRAs. The HHS OIG may issue its report in 2024. If this occurs early in 2024, this could give CMS enough time to consider major restrictions or a bar to HRAs in risk adjustment for the 2026 rule. That rule will have to be issued in interim form by late 2024. Or the restrictions could occur with the 2027 rule, which would be issued in interim form by late 2025. One catch here is there's a big lead time of bid and rate submissions each year, and the fact that a rule would not be finalized until plans are well into the processes for the next calendar year. Thus, the effective date of any changes would need to lag the effective date of the rule by at least 1 year. That means any HRA bar might be effective in 2027 if it was in the 2026 rule, or in 28 if it is in the 2027 rule. Let's talk manual chart reviews. CMS would also need to do this by rule. It could theoretically do this in the 2026 rule, but more likely this would take more time and perhaps move to the 2027 rule, issued in interim form in late 2025. Whatever the actual year, I would bet that CMS would structure the move away from manual chart reviews in a phased way, much as they approach the phase out of the old risk adjustment payment system process in favor of the Encounter Data Submission 837 process, or EDPS, that I described earlier. At the time, CMS was sensitive to the revenue impacts on plans that were not ready for the more complex Encounter submission process. CMS likely would have those same sympathies here as well, despite their concerns about overpayment. Thus, the manual chart review phase out could be phased in over a 3-year period as one example. The possible scenarios include the following based on the big lead time of bid submissions each year as well. If it was in the 2026 rule implementation, there would be a 1/3 weight phase out of manual chart reviews in calendar year 27, an additional one in 28, and chart review would be gone in calendar year 29. If it was in the 2027 rule, there would be a 1/3 phase out of manual chart reviews in calendar year 28, another third in calendar year 29, and chart review would be gone in calendar year 2030. What would plans need to do if these HRA and these manual chart additions to risk adjustment happens? Many would say it's sort of a long time off, but when you think about it, it's really not. So while the horizon for changes for each looks long, plans would have to begin really preparing now. Plans would face major reductions in overall revenue if both the HRA and the manual chart chase processes went away for risk adjustment. This would be especially true for those so-called bad actors. Plans complained about the impact of the new risk model phased in from 24 to 26. We know benefits will realign because of the financial problem in MA right now. The impact clearly would be far greater if one of these or both of these changes went through. Plans would really need to totally rethink how they capture diagnoses for risk adjustment in many ways. Here are a few of my thoughts. They're by no means exhaustive, but they might help plans think through the possibilities of the future if these things do come true. Many plans continue to have poor end-to-end encounter submission processes. Indeed, it is easier to paper over these and default to a manual chart process. Plans would need to reinvest in encounter excellence, from upfront provider relations training and work and education to encounter assessment to submission and remediation, really major investments in the entire process. As is done to some degree today, plans could analyze claims and other data to notify physicians of potential missing diagnoses and risks. This would be a reasonable substitute for even more retroactive manual chart activities. Upfront analysis, getting in on an encounter from a provider, would solve the problem of overpayment. Plans would also need to work with CMS to define how the world of interoperability will impact risk adjustment moving forward. It offers the hope of finding diagnoses directly tied to physician encounters hidden in the EMR systems that never make it to an encounter. Indeed, the basis for manual chart reviews was because providers do not document every health risk in encounters, something I've pointed out that MA plans try to do that the fee-for-service providers do not. The problem is plans may have taken this way too far in some cases on manual chart review. So just a few ideas of how plans could overcome what I believe are very possible reforms of both the use of HRAs in risk adjustment as well as manual chart review. With that, we'll conclude this edition of the Healthcare Labyrinth Podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.